Just to remind you that sleep is different at different stages of life, and you have to take that into account when somebody has a sleep complaint. Abnormal sleep, the initiation and maintenance, the insomnia group, and the phase advance, phase delay group. These are the late to bed, late to rise teenagers, and the early to bed, early to rise, often older people. Disorders of excessive sleepiness, the most common of which is just not enough sleep. Obstructive sleep apnea is as common as asthma in your practice. You may not have found them all yet, but it's very easy. In South Auckland, you walk outside and the first person you touch has it. Narcolepsy, uncommon, but I saw a lady in Gisborne the other day who was 33, has had symptoms since she's 17. She's had 3 jobs that she's lost through being found asleep at work, and she's easy to diagnose and treat. Restless leg syndrome, periodic leg movements, again, common in your practices, but usually doesn't require treatment. The patient just needs to be reassured and taught that movement is good. Some people with restless legs are difficult to treat, and please refer them to Stuart Jones. Abnormal behaviours during sleep, these are the sleepwalking, sleep talking, and the hitting out. REM behaviour disorder, common in older men, and pre-stages the development of Parkinson's disease or multisystem atrophy. Epidemiology. Every talk has one of these. So how might these people present? Well, the patient might have a complaint, and it can be subtle. Night gastroesophageal reflux is not an uncommon complaint. Sometimes the partner will come in. If the partner comes in and speaks in words of one syllable, you know that there's a problem. You need to suspect this under certain circumstances, particularly difficult hypertension, new onset atrial fibrillation, the so-called dawn phenomenon, where morning blood sugars are very high in diabetics, and then you increase constantly the night insulin, and then they start getting hypos later in the day. That's almost always the adrenaline and the insulin antagonistic effect of adrenaline from repeated attempts at death in the night. People with congestive cardiac failure, and then some obvious associations. Sometimes the employer notices it, particularly if a Ruawai truck driver doesn't take a gentle bend at the end of a 3-kilometre straight and writes off his $250,000 truck with its $200,000 load. Commonly, truck drivers might be picked up while they're waiting for a load. The truck gets loaded and the truck doesn't drive off, and that attracts some complaints. This is relatively straightforward. This is an old, very old oximetry printout, just pointing out that this is a physiologically disturbing disorder. The strip on the bottom is a continuous blood pressure record, and you can see that blood pressure goes up 40 points during these obstructive episodes. This is not good for you. So a number of complications, 2 to 7 times more likely to have a crash, increased work accident, impaired performance, and there are a few things that are associations but not necessarily causal. So where might you send the patient? Well, a snorer, whether they're sleepy or not, whether you suspect that they have sleep apnea, if they've got a blocked nose, then that needs to be dealt with first. If it's a structural blockage, then they need to go to an ENT surgeon. If it's mucosal obstruction, then you need to treat with nasal steroids. And then there's a range of options. I understand you'll get these slides. So we've talked a bit about when to suspect sleep apnea. How many of you have nodded off in a meeting? Okay, we'll set up an extra special clinic on a Saturday morning. This is a real photo, fortunately in America, over the Grand Canyon on a sightseeing tour. This again is an old slide, but this is an observational study done in Spain where they have excellent network of specialist centres, just showing that people with untreated sleep apnea have more heart attacks or cardiovascular disease, and if they're treated and compliant on treatment, that improves. If they don't use their CPAP device or have other treatment, then they're just as bad as the untreated. The ones that comply with CPAP, a lot of people are negative about CPAP, particularly ENT surgeons, but for those that present with a personal complaint, doctor, I have this problem, please fix me, they are much more likely to be compliant on therapy. Those that are sleepy and those with more severe sleep apnea where they notice a difference on therapy. So I can't emphasise this slide enough. There's a lot of patients in the population that they don't yet know they're patients. If they present to you with symptoms, they then become a patient. You can detect some patients by asking the appropriate questions. If you don't ask the question, you won't get an answer. And there are those that are detected by a regulatory authority, and they are very difficult to treat because they know they don't have a problem, even though their eyes are close together. I'm going to skip through this, except to emphasise perhaps this problem of the nose and tonsils. It's pointless having somebody wait 4 months on a wait list for a sleep clinic if they've got tonsils that meet in the midline. And the ENT surgeons will act quickly in that setting if they are sleepy. If they're not sleepy, it's the don't call us, we'll call you wait list. I'm just going to skip through this because of time. So our process is that you guys make a referral to us. We grade it, generally reasonably quickly. We do daily grading at counties. P1 patients for counties are generally dealt with within 2 to 4 weeks, and they have split studies outsourced to private. The P2 ones all have oximetry. Now, oximetry misses about 1/3 of patients and underestimates the severity. But it's a very good case-finding tool for severe sleep apnea in patients without comorbidity. It's hopeless if you've got comorbidity, because if you're sitting already well down on the oxygen dissociation curve, even a minor breath hold will cause a desaturation and you'll get false positive results. The oximetry, I just jokingly describe it as a fat, hairy caterpillar. So if you've got a broad line with repeated dips, then that's repeated nocturnal events. Not necessarily obstructions, because central apnea can look the same if you've done the test in the wrong patient. All others get referred to a medical sleep clinic, and the P3 list is something for you guys to deal with. So, which drivers do you want to put off the road? Now, this is a vexed question, because most sleepy drivers don't have sleep apnea. And most people with sleep apnea aren't sleepy. It's just a few things that are predictive. If somebody's had a sleep-related crash in the past, they're much more likely to have a crash again. So they should be stopped straight away, and an appropriate referral made and saying, I have put this person off the road. And that will increase the priority for the receiving grader. History of near misses. somebody who's drifted off the outside their lane, pull back. If they do that repeatedly, they are high risk. Those where a driver could cause a catastrophe. Petrol tanker drivers. I drove to Northland 2 weeks ago and came on a truck with 150 metres of tyre mark in the gravel before he just gently drifted into a ditch. Fortunately on the left. The Tongan bus driver who killed patients in Gisborne a year or two back had sleep apnea. There are 3 truck crashes so far this year that I know are sleep related. This is not just a theoretical problem. Now I'll notify when my trips to the far north are so that you can stop anyone going on the same roads as me. Now I have a sleep questionnaire which was designed for primary care, and those of you who are interested in having it, you're welcome to it. If you just email me at either of those addresses. It's a 5-page thing that you see the patient once for 5 minutes. All you have to do is to ask the 3 system review questions relating to sleep. How do you sleep at night? Are you sleepy in the daytime? And do you snore habitually? And then you hand them the questionnaire and you make them go take it home and reschedule them for a week's time. And they'll bring it back for you, and there's an examination bit on the back that you may or may not find useful, and then that can serve as a referral. Thank you.